Hello everyone and welcome to another session of Next Saviours Essential Question Series NEET PG 2025 where we discuss the most likely question to be kept in your examination, and today we'll be discussing about the CPR. You know, if you are sitting in NEET PG 2025 examination, then no doubt there is going to be a question on CPR, and let's make it easier for you how to identify the question and how to mark the answer correctly regarding the individual question related to this particular topic. So let's see a sample question, like how the questions are usually framed and what are the things that are needed to be identified in that particular one, because majority of the times if they want to ask you then when to initiate the CPR, then they will provide you a long clinical question like 65-year-old came to the emergency, complain of sudden onset of chest pain, shortness of breath, diaphoresis 30 minutes ago, history of hypertension, type 2 diabetes mellitus, chronic smoking. He appears pale, anxious, and clutching his chest. His vital signs are blood pressure is low, heart rate is high, respiratory rate is too high, oxygen saturation is dipping. The ECG shows ST segment elevation in 2, 3, and AVF. Now, from here, the question becomes important. Like, while being prepared for immediate reperfusion therapy, as you know, the patient is suffering from ST segment elevation myocardial infarction, the patient suddenly becomes unresponsive, stops breathing, and has no palpable pulse. Now, what is the most appropriate immediate management for this patient? And the options which are provided are these are the options. We'll see this question again, but now let's talk about the topic, that is CPR. Each one of you should be knowing about in CPR is number one, indications, that when exactly to start. I mean, when to recognize it rapidly and start the CPR. Second is the chest compression, because what they usually ask is the rate, the depth, and the ratio of the chest compressions. Then is the airway management. Apart from this, if at all the endotracheal tube intubation is required, then what exactly are the indications related to that? Then the fourth one is defibrillation. What are the specific indications? What is the placement? These are the things that we will be talking about. Most importantly are the medications. What are the specific medicines which are used, when to use, and what to give, and what is the rate and what is the dose that is required to be given. And finally, the post return of spontaneous circulation care. So this is how the CPR is broken into, the topic CPR is broken into. And let's start with the indications of the CPR first. Now imagine if there is a patient who is unresponsive, or if the patient is breathing either abnormally, like there is gasping, or there is no breathing at all, absent breathing, you go on checking the pulse. Now carotid pulse has to be checked in case of adults, while brachial pulse has to be assessed in case of infants. And if there is no feel for less than or equal to 10 seconds, then don't waste your time and start CPR immediately. All right, so these are the indications for CPR. Then obviously the first thing that you have to start with is the chest compression. The first thing that they used to ask multiple of the time is the 100 to 120 per minute is the rate. You know, all these are given according to the most recent American Heart Association guideline that was given in 2020. Now, depth as far as adults are concerned, at least 2 inches, that is 5 centimeters, but it should not exceed beyond 6 centimeters. In case of children, it should be one third of the chest depth, that is around 5 centimeters in children and 4 centimeters in case of infants. Now as far as ratio is concerned, it has to be 30:2 in case of adults, while it has to be 15:2 in case of infants. Basically what is 30:2? It is 30 chest compression which is followed by 2 rescue breaths. And how these rescue breaths are provided? With the ambu bag that we'll be talking about later. Now 15:2 for infants. Now what is the role of this rescuer? Like 2 rescuers or a single rescuer is required, because we have to minimize the interruptions in between the chest compression. Like there has to be limited pause, and that pause is recommended to be less than 10 seconds. There has to be a continuous chest compression along with the rescue breaths. Then comes the airway management. As you know, majority of the times the CPR has to be initiated by putting the back mask ventilation with a high flow oxygen first. Now, what are those cases where endotracheal tube intubation is required? For example, imagine if the patient comes to you who is having a severe airway compromise, which could be because of trauma, because of burns on anaphylaxis, or a patient is having a high risk of aspiration, vomiting, airway secretions, or where the CPR is expected to be prolonged, or if there is inadequate oxygenation, so despite giving the back mask ventilation, then in those cases we have to go for endotracheal intubation. Now, before performing the endotracheal intubation, you have to pre-oxygenate the patient with 100% of the oxygen for 30 seconds, if at all, if it is feasible. Then perform a rapid sequence intubation if spontaneous circulation returns. Now, majority of the times in CPR, intubation is usually required or is done when the spontaneous circulation returns. And then obviously you have to confirm whether the endotracheal tube placement is correct or not. That has to be, means it can be done by capnography, where the ATCO2 is more than 10 millimeters of Hg, or bilateral chest rise. One more thing is that, the ratio for bag and mask ventilation is 32 in case of adults. But in case if the patient is intubated, asynchronous ventilation, that means one breath every 6 seconds has to be given in the airway management with endotracheal intubation. Then coming on to the rhythm assessment. You see, you have started with the CPR, and for example, on the monitor, you can see the rhythms. The rhythms can be seen in the monitor. Now, these rhythms can be divided into two categories. One is shockable rhythms. That means if you provide a shock to the heart, then these rhythms can be improved. Another one is non-shockable rhythms. So if the rhythms are found to be shockable, like in case of ventricular fibrillation, in case of pulseless ventricular tachycardia, then yes, you have to defibrillate the patient immediately. Give one shock, biphasic, in case of biphasic, 200 joules, in case of monophasic, with 360 joules. Now, some of you might be thinking that where exactly we have to keep the pads on the chest wall while giving this defibrillation. Now, imagine if this is the chest of the patient, and this is the right side, and this is the left side. Then the most common site or the standard AED pad placement is anterolateral, which is most common. The pad one is placed below the right clavicle above the pectoral muscle. In case of right side, it is just below the clavicle. The pad one is placed right over here, while the pad 2 is placed on the left side of the chest in the mid axillary line, which is below the level of the nipple. So pad 2 is placed in the mid axillary line over here. So this is the most common side. All right. So this is how you can remember it: right high, left low. And why this placement? Because it creates a vector through the heart for the maximum flow of the current. So this is the placement of the pads. Although this question has not yet been asked till date, but there is always a possibility. Now, after that, what you have to do is resume the CPR immediately for 2 minutes before rechecking the rhythms. So this is the indication, a specific indication for automated external defibrillators. Now, on the other hand, if the rhythms are non-shockable, like if there is complete asystole or there is pulseless electrical activity, there are no rhythms at all, then ultimately you have to proceed with the CPR and epinephrine. Now, how much? What is the dose? What is the rate? This is what we are going to discuss in the next segment. Next segment are those of the medications in cardiopulmonary resuscitation. You know, the most important medicine to be provided is epinephrine. You have to remember the dose. It is 1 milligram intravenous every 3 to 5 minutes, as early as possible for non-shockable rhythms, but for after second shock for the shockable rhythms. And as far as indication is concerned, for all pulseless rhythm, it has to be given epinephrine in case of CPR. Another one is the amiodarone, but amiodarone, it is used for ventricular fibrillation or paroxysmal ventricular tachycardia. The dose is 300 milligram IV bolus, which is repeated with 150 milligram IV if there is a persistence. Alternative is also there, like lidocaine. Now, rest of the drugs are used as far as indications are required, or in order to reverse the causes which are responsible for the cardiopulmonary failure in the patient, like sodium bicarbonate is required for severe metabolic acidosis, hyperkalemia, or tricyclic overdoses. Now, calcium chloride is required for hyperkalemia, hypocalcemia, or calcium channel blocker toxicity. It has to be given slowly. This is very, very important that whenever you give calcium chloride, it has to be pushed very slowly. And finally, magnesium sulfate for torsades de pointes. Most important is the epinephrine that has to be given throughout the process of CPR every 3 to 5 minutes. So this is the role of medications in the CPR. Now imagine for lucky patient, if the patient has survived, like If there is a return of spontaneous circulation is achieved, then what is the advanced management? Now, the aim is to maintain the mean arterial pressure of more than 65 millimeters of Hg either through fluids or through the NORADs, noradrenaline, that means vasopressor, if at all required, and and consider a targeted temperature management means cooling to 32 to 36 degree centigrade for 24 hours. Also very important is to identify and treat the underlying causes. There are some underlying causes, means all ICU in charges are aware of this, like which are reversible. If I give you some examples like tension pneumothorax, tamponade of the cardiac, drug overdoses, the thrombosis, minor trauma, the hypothermia, the hyper or hypokalemia, the hypoxia or hypovolemia or acidosis. So these are the reversible causes, and you have to treat the underlying cause. One, the spontaneous circulation is achieved. So this is in total everything related to the CPR. So what are the key points, if you want to remember it, if you want to revise it, what are the key points that we have discussed, or what are the key points the examiner usually focuses on? Is the compression to ventilation ratio that they used to ask. In case of intubated patient, as I told you, the things are slightly different, like continuous compression plus one breath has to be pushed after every 6 seconds. The shock energy for biphasic, it has to be 200 joules. For monophasic, it has to be 360. The placement of the pads we have already discussed, right high, left low. The first drug in asystole is epinephrine. The first drug in refractory ventricular fibrillation or paroxysmal ventricular tachycardia is amiodarone. Bradycardia with hypotension, atropine is the drug. So these are the key points that you have to remember related to the cardiopulmonary resuscitation, over which hundreds and thousands of the questions have already been asked. Now, a sad part of the CPR is, and a practical one is, that what are the points or what are the indications where you have to stop CPR and declare the patient dead? If there are no signs of life, like no breathing, no pulse, no neurological improvement or response, despite a high quality CPR of more than 30 to 45 minutes without any sign of spontaneous circulation. Another one is when there is no shockable rhythm throughout the process of resuscitation for the same time period of 30 to 45 minutes. And end tidal carbon dioxide levels are found to be less than 10 millimeters of Hg even after 20 minutes of CPR. And you have already recognized that the indication for the cardiopulmonary failure is irreversible. Now, in those cases, you have to stop the CPR and declare the patient dead once you have tried your level best. So, hopefully, you have understood everything related to the important components of the CPR. Now, if you go back to the question, we have already read the question in detail. So, as you can very clearly see that while being prepared for immediate reperfusion therapy, the patient suddenly becomes unresponsive, stops breathing, no palpable pulse. These are the clear-cut indications for starting the chest compressions and prepare for defibrillation if at all required. That means you have to start the CPR immediately. Hope you have understood this question. All the best for your future examination. Keep yourself updated. Join our Telegram group. Link is provided. All the best.